All right, just to kind of confirm, you guys can hear and see my screen right now, correct? Everyone, anyone on Zoom, please. Just before I get started. Thank you, Dr. Bradley. So I'm going to get started. We've got a few slides to go here. So I'm going to be talking about scleroderma-associated lung disease today. Special thanks to Dr. Abdul Hameed, who really helped me a lot with these slides and can I help finesse them to the best possible presentation this can be. I have no financial disclosures. I will be discussing some non-FDA approved therapies in scleroderma-associated lung disease today. My general outline is going to be first talking in some general introduction about systemic sclerosis. The second part of the presentation is going to be mainly focused on the pulmonary manifestations of systemic sclerosis and in general evaluation of lung disease when you have a patient coming in with scleroderma. And then I'm going to go on, my primary focus of this talk is going to be on scleroderma-associated interstitial lung disease. Kind of go through the etiopathogenesis, the different patterns, the staging, and then the big focus will be on treatment of scleroderma-associated ILD. There's been quite a few new therapies and significant changes in this realm, so we'll be spending quite a bit of time on treatment. So as you all are aware, scleroderma, systemic sclerosis or scleroderma, is an autoimmune disease that's characterized by fibrosis, not just of the skin, but also internal organs, and a vasculopathy. So it's kind of a combination of fibrosis and vasculopathy. It's designated as an orphan disease. Prevalence is anywhere between 50 to 300 cases per million persons, and the incidence is anywhere between 2.3 to 22 cases per million persons per year. It is the female to male ratio, as with other autoimmune diseases, there's a female predominance. And the range can be anywhere between 3 to 1 to 14 to 1, depending on what epidemiological studies you're looking at. The mean age of diagnosis is in the 40s for men and women. African Americans have an earlier mean age of diagnosis. And as we all know, we must have seen patients in clinic who come in with scleroderma who have had the disease for a few years, but they come in a lot of times with interstitial lung disease being the first manifestations, and hence diagnosis is often delayed. It does carry a high mortality, greater than any of the other rheumatological disorders, and it is the most common autoimmune cause for connective tissue disease, ILD. In general, when we classify scleroderma, these are the four big classifications, four big types that we talk about. So there is a limited cutaneous type, there's the diffuse cutaneous type, there's a sign scleroderma, which is associated with no skin thickening. You can still have organ-based, fibrosis and vascular manifestations, and then overlap of scleroderma with other autoimmune diseases, primarily myositis comes to mind. But the big two are the limited cutaneous and the diffuse cutaneous. When it comes to limited cutaneous, there's high risk of pulmonary hypertension, and usually they carry a long history of Raynaud's. Whereas with diffuse cutaneous, they typically have a shorter history of Raynaud's, and there's increased renal crisis and a higher risk of pulmonary fibrosis, interstitial lung disease with diffuse cutaneous. One important distinction is the limited cutaneous. The skin sclerosis distribution is as it's mentioned, it's usually limited, and with more diffuse, you're going to have proximal limb involvement and trunk involvement with skin sclerosis. The etiopathogenesis is considered complex. There is a complex interplay between genetics and other environmental factors. Now, when it comes to genetics, it primarily involves genes that encode for polymorphisms of genes that encode for cytokines and other cytokine receptors. There's and HLA class 2 has been implicated, especially with some with development of autoantibodies. Surprisingly, there are some environmental triggers. Chemotherapy agents are some of them. Silicone breast implants have been implicated, and also some organic chemicals such as vinyl chloride monomers. So when we talk about the pathophysiology of scleroderma, you have an early stage and the later stage. The early stage typically involves vascular injury being preceding the more the later development of fibrosis. So you have microvascular damage, you have inflammatory infiltrate. coming into the tissues, and then you slowly develop fibrosis. And the later stage, the fibrosis gets more pronounced, and then you develop skin atrophy. So overall, it's not just the autoimmune factors that play a role, but also you have reactive oxygen species, you have the direct vascular damage, and pro-fibrogenic cytokines playing a role, including TGF-beta and PDGF. This schematic kind of goes through the pathophysiology in more of a pictographic representation. So initially you have the triggering, which happens because of immune mediated damage to endothelial cells, and then you have the amplifying mechanisms, wherein the cytokines now come in. There are more and more autoantibodies, which primarily involve the platelet-derived growth factor, and then you have and this is where fibrosis starts to begin. And the more and progressive, there is progressive fibrosis, which ultimately results in organ derangement. This schematic kind of just focuses, on the different pathophysiological pathways. What I'd like to focus is primarily looking at the PDGF and TGF-beta being two of the important cytokines that kind of play a role in the fibroblastic response in scleroderma. Now, when we talk about autoantibodies, this is a good pictograph of all the autoantibodies that are typically implicated with scleroderma. You have the anti-topoisomerase 1 antibody, which is also the so anti-topoisomerase 1 is implicated in diffuse cutaneous, and then you have the anti-centromere antibodies, which is implicated in limited cutaneous. The other autoantibodies that are involved are the RNA polymerase 3. You have the polymyositis, the anti-polymyositis, anti-sclerosis antibodies. You have the U3-RNP, which is also called the anti-fibrillarin. Some of these are not commonly measured. Now, I'd like to kind of bring your attention to these three images here, which are basically the ANA staining patterns that we see. The first one is the speckled staining pattern, which is implicated in diffuse scleroderma and is associated with anti-topoisomerase 1 antibodies. And the second one here is more of a homogeneous pattern. And the homogeneous pattern, as expected, would involve anti-nucleolar antibodies. So the antibodies are directed against nucleolar antigens, such as RNA polymerases, fibrillarin. So these are more commonly implicated in the overlap syndromes. And the last one here is basically looking at the anti-centromere staining pattern, which is more with the limited cutaneous scleroderma and is associated with high risk of pulmonary hypertension. So some of the common antibodies that are involved. Talking about overall clinical manifestations of scleroderma, we know that cutaneous involvement is the most important organ involvement. And as I mentioned, limited is usually limited to the skin over the fingers, the hands, the face, and the neck. With more diffuse, you have involvement of the arms, the trunk, and lower extremities. And they go through these phases, which are the initial edematous phase, and then you have the indurative and the atrophic phases. Some of the earliest changes that we see are just sclerodactyly, which is diffusely swollen fingers and hands. And this progresses into skin thickening. Initially, the skin thickening can be very subtle. All you can see is probably the inability to tend the skin over the fingers, and with time, the skin becomes more and more atrophic and immobile. Vascular complications. It typically involves the tip of the digit, so you can have digital infarcts, you can have subungual infections. Another feature is poikiloderma, which is hyper and hypopigmentation, which is mixed, giving the skin a salt and pepper appearance. Facial involvement is common. Sometimes it can just present with difficulty eating, and it can be limited only to the oral aperture. Sometimes patients can be devoid of wrinkles, so they look more younger than what they are. And calcinosis, which can be present in 25% of the patients. Vascular involvement, as we know, presents with Raynaud's and other digital ulcers. These are some images of diffuse cutaneous scleroderma in the different changes that we see. This is more with the limited cutaneous involvement of the face, the neck, the facial telangiectasias here, the dilated nail fold capillaries, and calcinosis. This is the poikiloderma that I was talking about, which is the salt and pepper appearance that we can see. And here in the tip of the fingers here, you can see the calcinosis that can develop. So after the skin, musculoskeletal involvement is common. And this is one of the fewer rheumatological illnesses that can affect the distal interphalangeal joints. You also have autoamputation at times, and that is because of acroosteolysis, which is basically resorption of the terminal bony tuft of the fingers. In addition, the other organs that are typically involved are the GI and kidneys, along with the lungs. When it comes to GI, the involvement can be quite extensive. Most patients, 80% of the patients, can have involvement of the distal esophagus presenting as dysmotility and GERD. They are at increases for Barrett's esophagus and adenocarcinoma. Gastric dysmotility is another important feature, and the other important features include what is called as watermelon stomach and watermelon colon. Watermelon stomach and watermelon colon basically refers to vascular ectasias in the stomach and in the colon. You can also have things such as small intestinal dysmotility and bacterial overgrowth. Renal involvement used to be very common before, and scleroderma renal crisis was once considered the chief cause of mortality. Now it affects only about 5% of the patients. Typical risk factors are patients who have diffuse scleroderma, presence of anti-RNA polymerase III antibodies, and as we know, the association of glucocorticoids. And we'll discuss one of the studies later on that kind of looked at what dosage of glucocorticoids are typically associated with scleroderma renal crisis. Scleroderma renal crisis presents with hypertensive emergency, so features of headache, encephalopathy, and lab studies would demonstrate microangiopathic hemolytic anemia, schistocytes, thrombocytopenia, and elevated creatinine. The 2013 EULAR and American College of Rheumatology classification scheme for scleroderma takes all of these things into consideration. It's mainly for research purposes, but it gives us an indirect clinical assessment of diagnosing scleroderma. So a score of 9 is needed for definite classification, and it involves some of the things that we discussed earlier, including different skin involvement, autoantibodies, and either presence of pulmonary hypertension or pH. Overall investigation strategy kind of looks into different organ involvement. So looking for pulmonary hypertension, fibrosis, looking for GI symptoms, looking for evidence of cardiac and renal disease. And in terms of overall treatment approaches, again, depending on which organ system is involved, your treatment is going to be directed against those systems. Moving on to the pulmonary manifestations of scleroderma. Scleroderma affects the lungs in multiple ways. The most common involvement is scleroderma-associated interstitial lung disease. Approximately half patients with diffuse scleroderma have ILD, and about 25% patients with limited scleroderma have interstitial lung disease. Typically, the onset is subacute, dyspnea on exertion, sometimes a non-productive cough. Patients with scleroderma can present with recurrent aspiration. The typical radiographic features are what are called as centrilobular fibrosis. They have a patchy centrilobular distribution of ground glass and consolidative opacities. Pulmonary vascular disease is common. 10 to 15% of patients with scleroderma have pulmonary hypertension. The other vascular manifestations include thromboembolic disease, PCH, and PVOD. You can also have pleural involvement in the form of pleural effusions, which are usually lymphocytic predominant exudative pleural effusions. You can have spontaneous pneumothoraces. Airway disease is another important manifestation, sometimes just presenting with airflow limitation, but at times we can have follicular bronchiolitis, you can have cylindrical bronchiectasis. Scleroderma puts you at higher risk for lung cancer, and this has been shown to be independent of smoking. And a lot of times, this is the respiratory muscle weakness is an important thing to keep in mind. I've seen a patient with scleroderma who was on appropriate therapy, but with increased symptoms, who actually turned out to have, respiratory muscle weakness. And this can be, one of the contributing factors in our patients with scleroderma. It is and typically present with hypercapnic respiratory failure. And, typical, like what we saw in the other patient, was even though you're on appropriate therapy, you're symptomatic. The patients can be symptomatic. And the other is drug-associated pneumonitis. Overall evaluation when a patient with scleroderma comes to the clinic, any patient with new diagnosis of scleroderma should be screened for ILD and pH because the incidence is so high. And the evaluation typically involves clinical assessment. Assessing for pH becomes important, so doing a pro-BNP. We'll proceed with PFDs and typically what to look for PFDs in the subsequent slides. But one important thing I wanted to mention was the Fpc Dlc ratio. This is especially important when if the degree of impairment of DLCO is kind of out of proportion, then doing an Fpc Dlc ratio can be important. A ratio of about 1.6 may suggest the presence of pulmonary hypertension and not just ILD alone. And then we proceed with also doing a high-resolution CAT scan. High-resolution CAT scan, and we'll be discussing some studies that look at what is the utility of high-resolution CAT scan. It's not just for diagnosis, but there is also prognostic and utility and also evaluation of treatment response. And echocardiography. And these are some of the common signs of pulmonary hypertension on an echo. So right ventricular enlargement, right atrial enlargement, presence of a high-velocity tricuspid regurgitation jet. Typically, when we see a pulmonary artery systolic pressure above 35 to 40, that correlates with regurgitation jet velocity of more than 2.9, and that would be suggestive of pulmonary hypertension. And when pH is suggested, these patients should undergo right heart catheterization. Subsequently, in patients who come in and they don't have ILD or pH on initial evaluation, they still remain at risk. So follow-up visits should be anywhere between 3 to 6 months for symptoms and physical exam. Annual PFDs are typically done in the first several years, and later on they can be spaced out depending on how the patients are doing. Typically, patients who've got long-standing scleroderma or have normal DLCO, not a lot of symptoms, you can space them out to every 2 to 3 years. The timing of repeat high-resolution CAT scan, again, depends upon what the clinical and PFD progression of the disease is. If the patients are more rapidly progressing, then we may need to repeat imaging sooner rather than later. And repeating BNP and echo every 1 to 2 years to look at pulmonary hypertension is also something important. So as of now, we kind of went over some aspects of scleroderma and also overall pulmonary manifestations of scleroderma and just an initial evaluation of a patient with scleroderma presenting with lung disease. And now we'll proceed with scleroderma-associated interstitial lung disease. With ILD, I'm kind of going to first go through overall the general pathophysiology, which is similar to what we discussed in terms of overall pathophysiology, but there are some differences, and then kind of go through which patients with scleroderma are at increased risk for ILD, and kind of go through the diagnostic pattern of systemic sclerosis ILD in general. So lung fibrosis is common in scleroderma. In almost 80% of patients with scleroderma have some degree of lung fibrosis, and about 25% of all patients with scleroderma develop progressively worsening interstitial lung disease. 35% of all scleroderma-related deaths have been attributed to pulmonary fibrosis, so it is definitely the leading cause of mortality in this patient population. And the course can be very variable. So some patients can have just limited stable lung disease, whereas others can have rapidly progressive worsening lung disease. The pathophysiology is similar to what we discussed before. If you remember, it was mainly the vascular insult initially and then going on to have fibrosis. But here, what we see mainly is architectural disruption and the collagen-rich accumulation of collagen-rich tissue within the extracellular matrix. And this involves an interplay between the epithelial endothelial cells and interstitial compartments. What is really recognized is you have repetitive damage to the epithelial endothelial cells that kind of set off this fibrotic reaction. Initially, you just have activation of fibroblasts, and then these fibroblasts kind of differentiate into myofibroblasts. And these myofibroblasts accumulate in the extracellular matrix, eventually leading to interstitial lung disease. So this kind of pictograph, again, looks at what I just talked about, and that is the initial, if you see the initial, what sets it off is basically repetitive endothelial epithelial damage, which results in immune cells infiltration, more and more inflammation, activation of fibroblasts. So that is what progresses the lung injury. And later on, these fibroblasts kind of differentiate into myofibroblasts, and now the myofibroblasts persist, and there is, the persistence of the pro-fibroblastic cytokines, and you have more and more fibrosis happening. Patients who are typically at risk, some of the risk factors are a little different. The risk factors for patients who develop progressively worsening ILD include patients with diffuse scleroderma. They have a high risk for progression. African-American males are at higher risk for progression. And what is synchronous with diffuse scleroderma is the presence of anti-SCL70 antibodies can these patients are at risk for progressive ILD. In terms of which patients with scleroderma have more severe disease, typically the patients who at onset have a higher extent of disease on high resolution CAT scan, DLC, low DLCO and lower FVC, as expected, right? These patients are more have more advanced disease, or they have the more progressively worsening disease. So typically these are at higher risk for worsening later on too. There have been several models. Some of these have been studied in other, interstitial lung diseases, such as the GAP score, that can help in predict mortality of patients with scleroderma ILD. Clinical manifestations, a lot of times early ILD can be asymptomatic. The most frequent symptoms can just be shortness of breath and dry cough. And a lot of times ILD can be the first manifestation of connective tissue disease in these patients. Velcro crackles are heard, and that's probably one of the most characteristic physical exam finding. And other findings include just failure, right heart failure symptoms, corpulmonale symptoms. How do we evaluate patients who present for ILD evaluation and and scleroderma? Similar to other ILD, similar to other patients who come in for ILD evaluation. What is important to know is, because this is a connective tissue disease, ILD lung biopsy is rarely necessary. And our diagnostic tools, including spirometry and high resolution CAT scan, are mainly targeted to kind of characterize the type of ILD and also the severity of ILD, and also to rule out other causes for interstitial lung disease in these patients. Are there blood or BAL biomarkers? The answer is yes, but most of these are still being investigated in clinical research. Not a lot of them have, are used in clinical practice. There is something called the Krebs-Wanden-Lungen 6 level, which is, I think, one of the markers that can be used, but this is available only in Japan. C-reactive protein is one that can be used. C-reactive protein has been associated not just in predicting ILD severity, but also in predicting ILD progression. And another important prognostic indicator, which is being studied, is something called the CCF ligand 18. Again, these are things that are still in clinical practice. They're still being investigated. How about PFDs? PFDs are definitely, at the time, they are indicated at the time of initial diagnosis, and subsequently, at least performing it annually is important. In some patients, we may need to do it more frequently. The pattern of PFDs, can also help differentiate between what has been involved, right? So if you have ILD versus PH versus airway disease, the pattern of PFDs can help differentiate between them. When we look at PFDs, looking at all of them is kind of important, and the importance of the different PFDs, we'll be discussing in the subsequent few slides. So first, talking about spirometry and lung volumes, as we know, proportional reduction in FEV1, FVC with normal ratios can be suggestive of a restrictive lung defect, and that can be present with patients with scleroderma. However, what is really important is interstitial lung disease in scleroderma cannot be ruled out based on spirometry alone. This study kind of focuses on that point. This is published in the Journal of Arthritis and Rheumatology in 2015. And what they basically looked at was 102 scleroderma patients who came in, of which 64 patients had ILD on high resolution CAT scan, but only 27 had an FVC of less than 80%, and only about half had a decrease in any one of the PFDs. So either a low FVC less than 80%, a change in FVC of decrease rather in FVC of more than 10%, a total lung capacity less than 80%, or a diffusion capacity less than 70. So only about half patients had any one of these, and only about quarter of the patients had the FVC, which is typically seen as one of the most important tests that we do. So overall, what is important to remember is almost 62% of our scleroderma patients who have a normal FVC actually have ILD by high resolution CAT scan. So a high false negative rate. Another important thing to remember is when we look at FVC, when FVC is measured in the first 3 years from disease onset, it can actually predict whether or not these patients are going to worsen later on. So this study, again, published in the Arthritis and Rheumatology Journal, basically looked at patients and segregated them into an FVC above 80% on admission and an FVC below 80% on admission, and then and this FVC was done in the first 3 years of presentation. What they saw was near normal FVC at initial presentation has a lower risk for progression to severe ILD. So an FVC, as seen, can be not just diagnostic, but also important in prognosis and understanding which patients can progress. DLCO is, again, a very important thing to look at. Decrease in DLCO actually, this study basically looked at different indices of lung function, and they looked at the association of different indices of lung function to the extent of disease and worsening of disease on high resolution CAT scan. And what they saw was decrease in DLCO actually correlated best with severity of ILD on high resolution CAT scan. And it is also a predictor of poor outcome. So DLCO is important. How about 6-minute walk tests? 6-minute walk tests are important in interstitial lung disease. However, in scleroderma, I guess they'll have to be interpreted with a grain of salt. And that's because there are a number of factors that affect 6-minute walk tests. We just, when we look at a 6-minute walk test, we look at we look at the distance that's walked, but also we look at the degree of oxygen desaturation they had. A lot of our scleroderma patients, and this is something which I've seen in I think one of our patients who was admitted, was they can have Raynaud's, and when you have Raynaud's, they have poor finger perfusion. So sometimes you may need to use earlobe clips to do their 6-minute walk test. This study kind of looked at 6-minute walk tests between patients who had IPF. So they had 48 patients with IPF, 33 patients with scleroderma ILD, 13 patients with scleroderma PH, and then also 19 patients with both scleroderma ILD and PH. And what they found was pain limitations confound the utility of 6-minute walk tests. So a lot of patients are they fail to reach their dyspnea limitation because of pain. So 6-minute interpretation, should, when we look at 6-minute walk tests and having a low either walk distance, having a low walk distance should be taken in context of not just having interstitial lung disease, but also vascular involvement, musculoskeletal disease limitations. Things such as this should be taken into consideration. So that was kind of looking at scleroderma ILD as a in terms of like the general approach to scleroderma ILD. And now we will focus on different patterns and staging of scleroderma ILD. This is a little bit of an older study. This was published in Chest. What they basically did was they just looked at scleroderma patients within the within the SLS study, and they saw, or in the SLS study, everyone, patients who had scleroderma, what were the high resolution CAT scan findings that we could see. And the most common one was either any ground glass opacities or presence of fibrosis. Almost 90% of your patients had any of these. Some of the other things that we could see, pure ground glass opacities, only about 50% patients, honeycombing in about 37% patients, nodular disease in very small 0.6% patients. So high resolution CAT scan findings can be variable, but the more common ones are usually any ground glass opacities in presence of fibrosis. Can high resolution CAT scan, at baseline and following it up, can it predict the progression of disease? The answer is yes. And this study was again published in 2015 in the Arthritis and Rheumatology journal. What they did was they looked at 305 scleroderma patients, and they divided these patients into 3 subgroups. About 40 patients had more than 20% lung fibrosis, 108 patients had no fibrosis, and about 157 had anywhere between 1 to 20% fibrosis. And what they saw was, and the mean follow-up was 3.1 years. So approximately 3 years later, all patients who had no fibrosis were still free of fibrosis. In the second group of the 157 patients, 146 patients still continued to have 1 to 20% fibrosis, and only 11 of these patients actually moved into the first group, and that was, you saw progression. So extent of fibrosis on the initial CAT scan is actually an important marker of how patients will progress in scleroderma. How about the different patterns, the histopathological patterns that we see in scleroderma? This study basically answered the question. It was old study back in the Blue Journal. We see that about 78% of our patients with scleroderma ILD actually have the NSIP pattern, and the rest, about 7.5% have UIP, 7.5% have just the extensive fibrosing pattern on CAT scan on histopathology. These are some of the common patterns. As I mentioned, 78% patients have NSIP, and NSIP can be of either the cellular type or the fibrosing type. And this is the typical UIP pattern, which is the second most common pattern, about 7.5% of our patients. The other uncommon patterns rather that we can see are what is called a centrilobular fibrosis, which is typically seen in patients who have GI involvement. They have aspiration, and the other is the pleuroparenchymal fibroelastosis is the other pattern that can be seen. This is a landmark, kind of a landmark article in the scleroderma ILD literature, which basically divided scleroderma ILD into what is called as a limited disease and extensive disease. And what they basically looked at was dividing the HRCT disease extent into less than 20% and more than 20%. In patients who had indeterminate disease, they looked at the FVC. If they had FVC above 70%, they were put in this category of limited disease, and FVC less than 70% was put into this extensive disease category. And what they, after putting these patients into this limited and extensive groups, they basically followed them up and looked at survival and progression-free survival, and the stratification by this limited and extensive subgroups has been shown to be predictive of both progression-free survival and mortality. So this is kind of essentially putting it all into perspective, is kind of combining the HRCT findings and FVC put together, and then stratifying scleroderma ILD into the limited and extensive subtype really helps, in prediction of how these patients are going to progress over time. These images, I'm going to skip over these. These are basically more just images of the limited and the extensive disease subcategories. Now that we've kind of discussed scleroderma in general overall, and then also discussed scleroderma ILD, just a general introduction and different patterns, we'll move to treatment. And as I mentioned, treatment has there've been quite a few changes with treatment options for scleroderma that we have right now, beginning with what was the landmark scleroderma lung study 1, which kind of looked at cyclophosphamide, and then we moved on into scleroderma lung study 2, which kind of focused more on mycophenolate. And then more recently, the SENSKIS trial, which looked at nintedanib in scleroderma ILD, to more newer important options, and that is options such as rituximab, tocilizumab, and other options which are kind of uncommon in practice, and that includes hematopoietic stem cell transplant. And in the future, we will be looking at more the scleroderma lung study 3, which is looking at pirfenidone and other drugs such as abitazumab. So to begin with, why not steroids, or why not steroids in higher doses? And again, as we discussed earlier, scleroderma renal crisis there is an increased risk of scleroderma lung crisis with corticosteroid use. And this study kind of looked at a number of patients who they had 91 patients with scleroderma renal crisis, and they looked at different risk factors for scleroderma renal crisis. And one of the things that came out was corticosteroid use. And I think what is important to focus here is this 29 milligrams of prednisone. So about 30 milligrams of prednisone is kind of considered the dose that can potentially be associated with increased risk of scleroderma renal crisis. So when we're using steroids in scleroderma, we typically try to stay off of going beyond 30 milligrams, because this could potentially lead to scleroderma renal crisis. So that's an important thing to remember. And now, looking at the scleroderma lung study 1, and this was back in published in the New England Journal in 2006. Prior to SLS1, there were a number of medications that were tried, but none were proven to be effective. Cyclophosphamide, prior to SLS1, had shown some promise in some retrospective trials, but this was kind of a landmark article wherein cyclophosphamide became, it came on to the it really became important in terms of management of our scleroderma ILD patients. So SLS1 was a double-blind, randomized placebo-controlled trial. 13 centers in the US, we administered cyclophosphamide less than or equal to 2 milligrams per kg per day versus placebo for 1 year, and they were followed for an additional year. And the primary endpoint was FVC at 12 months, the change in FVC, percent FVC at 12 months. Inclusion, so here they actually included all scleroderma patients if they had evidence of active alveolitis on BAL or any ground glass opacity. So basically looking at more active scleroderma patients, FVC between 45 and 85%. And they had to have, and the ones who had grade 2 exertional dyspnea on what is called as a Muller dyspnea index, also called the transitional dyspnea index. They excluded patients with low DLC, very low DLCO, so less than 30%, and if they had PH and were on treatment. The baseline characteristics were pretty well matched. What SLS1 showed was a modest improvement. So at 12 months, patients who were treated with cyclophosphamide, they improved their FVC percent predicted by about 2.53% versus placebo, and this was significant. But I think what is the other important things to look at here, and if you look at this is basically, change of FVC from baseline. What is I think important to look at here is these 4 quadrants. Basically, patients who were on cyclophosphamide when compared to placebo had any improvement in FVC. So greater percent of patients had any improvement in FVC. It can be, the overall, it was about 2.53%. But when compared to placebo, 49% of patients on cyclophosphamide as compared to placebo, that was 26%, actually had any improvement in FVC, which was good. The other important thing is the opposite, and that is greater percent of patients in placebo had worsening of FVC when compared to cyclophosphamide. So in both categories, you had some who had improvement, some who had worsening, but patients with cyclophosphamide, more patients had improvement and less patients had worsening. The other thing that was important with the SLS1 was relationship between what happens to cyclophosphamide depending on the extent of fibrosis. And this was a scattergram that looked at FVC at 12 months, and the dotted line here is a cyclophosphamide, and this is the placebo line. And what was seen was in patients who had in the placebo group, if they had more severe fibrosis, they had worse FVC at the 1-year period. But as patients who had cyclophosphamide, their degree of fibrosis was really not dependent upon their FVC change. So irrespective of what their degree of fibrosis was, they showed improvement in FVC. So this was important because the degree of fibrosis and its relationship between cyclophosphamide was kind of important. The other secondary outcomes, they had improvement in TLC, the total lung capacity at 12 months. There was no significant difference in the diffusion DLCO over VA ratios, but there was also some modest benefit in their dyspnea scores, their skin thickening, and their health and their quality of life. They also did a longitudinal model on this, and they looked at benefit at 24 months, and they saw that the FVC, the difference was about 1.95%. So this longitudinal model at least showed that at 24 months you still had benefit of cyclophosphamide. There was obviously higher risk of adverse effects with the cyclophosphamide group, but serious adverse effects were not significantly different. So, when we talk of this, you're talking of, 2.53% FVC improvement. What is the clinical importance of this small treatment benefit? The answer is yes, I think there was some improvement because FVC is just one number. And I think this was supported by other things. So improvement in their dyspnea indices, improvement in skin thickening, and their overall health-related quality of life measures. So cyclophosphamide, just not just looking at the FVC, but overall there was significant treatment benefit. And what was important was this persisted at 24 months in the longitudinal model. So this was followed a year later. This was published in the Blue Journal. And what they did was they looked at these patients who who were in the SLS trial. And what we basically looked at here was the effect of cyclophosphamide at 2 years. So we did the follow-up, study for another year. And what was seen was other than the impact on this dyspnea index, all other effects kind of waned off after 2 years. So it was good, but once you discontinue it, the effects kind of wane off. So we were looking at other options. This was published in the Arthritis and Rheumatology journal a year before. That was around the time the SLS came out, and this basically looked not just at cyclophosphamide, but also having them on maintenance with oral azathioprine. And what was seen was when compared to placebo, this regimen, so having them on prednisone and cyclophosphamide initially, and low-dose prednisone and 6 months of cyclophosphamide followed by oral AZA, there was a non-significant, but there was a trend towards improvement in FVC. So we were looking at other options. And the other option came in the form of mycophenolate. This study was published in Chest in 2008. It was a retrospective review. Number one, it was only 13 patients, but what they did was they gave them mycophenolate for at least 6 months, more than 1 gram a day, and they compared their pre and post-treatment FVC decline. And what they saw was in the year prior to MMF, these patients had a significant decrease in vital capacity, and the average was minus 239 ml. And the following year, when they were given mycophenolate, they had a significant improvement in vital capacity by almost 150 cc's. So this was an important, although a small study, a retrospective study, but the pre and post treatment differences were quite obvious, showing some promise for mycophenolate. The diffusion did not really change though. So then came this SLS2 trial, which was published in Lancet back in 2016, randomized double-blind placebo-controlled trial looking at mycophenolate 1500 milligrams twice a day for 24 months and comparing this to cyclophosphamide for 1 year plus placebo. So they got cyclophosphamide for 1 year followed by placebo. 14 US medical centers. The hypothesis here was that MMF group may have a greater improvement in FVC. Inclusion criteria were very similar to the SLS1. They did have like other organ involvement as some of the exclusion criteria, and there were a bunch of other organ involvements that were taken into consideration. Again, baseline characteristics were pretty well matched. And what we saw was both treatments actually showed similar efficacy in terms of the FVC predicted improvement. So mean improvement was 2.19% versus 2.88% at 24 months. And also, this was also translated in, overall improvements in their transitional dyspnea indices and also the modified Rodnan skin score, which is basically skin thickening score. So not just FVC, but other, dyspnea indices and skin thickening scores too. But I think the most important thing that came out of this was that yes, mycophenolate had similar efficacy, but it was better tolerated in terms of patient withdrawals, in terms of treatment failures, and also in terms of incidence of leukopenia and thrombocytopenia. So overall, in summary, we did not find a significant difference in their course of FVC, and also in terms of the other secondary outcomes. So their dyspnea indices, their skin scores, there was no significant difference, but MMF was better tolerated. This was followed by, in 2019 New England Journal, when we now started looking at antifibrotics, and primarily we first looked at nintedanib. This was a randomized double-blind placebo-controlled trial again. The primary endpoint here was the annual decline in FVC, and the secondary endpoints were, again, the skin scores, which is the modified Rodnan skin score, and they looked at the St. George Respiratory questionnaire. Again, inclusion-exclusion criteria, these were actually pretty similar to the Impulses trial, which was done for IPF. And an important point to remember here is patients who were on prednisone up to a dose of 6 milligrams or were on mycophenolate or methotrexate for a stable dose for at least 6 months were actually allowed to be participated in the trial. So they could be on some mycophenolate. Baseline characteristics, again, were pretty well matched. What we saw was a significant difference. So the annual change in FVC over a 52-week period was lower in the patients who received nintedanib. So it was minus 52 cc's in the nintedanib group versus minus 93 cc's, which was an absolute difference of 41 cc's per year, which was significant. And this also translated in their skin scores and their their respiratory questionnaires. Adverse effects were very similar to what we saw in the Impulses trials, although obviously the GI side effects will be higher because IPF patients may not have as much GI side effects when compared to your scleroderma patients. So nintedanib after this became the first FDA-approved drug for treatment of scleroderma ILD. And the main treatment benefit here is to slow the rate of decline of FVC. And this became important. But again, going back to my point that in this trial, patients who were on mycophenolate were allowed to participate. So this was followed up, and this was published earlier this year in Lancet, and they basically stratified patients in the SENSKIS trial depending on whether or not they were getting mycophenolate at baseline. And what this post hoc analysis showed that the absolute decrease, the patients with absolute decrease of FVC at week 52 was, did not differ between patients who were on mycophenolate or not. So, nintedanib reduced the progression of ILD in patients in patients with scleroderma ILD, irrespective of whether or not they were on mycophenolate at baseline. And this kind of graph looks at that in a little more detail. I'm going to be skipping over this more quicker just for the because of time. So. So that kind of became important. So, irrespective of whether or not they were on mycophenolate, nintedanib is beneficial. Moving on to other therapies, and I think the two important things that we need to discuss are rituximab and tocilizumab, because we are increasingly using these therapies in connective tissue disease ILD overall, and scleroderma in particular. The evidence for rituximab is still kind of new. I mean, there are 2 active trials that are going on currently, and I'm going to discuss them in the next slide. But this was published earlier this year in the Rheumatology Journal. It was a systematic review meta-analysis on rituximab in scleroderma ILD patients. They included 20 studies, but only 2 of these studies were actually randomized controlled trials. And what they showed was that rituximab was associated with a significant improvement of FVC and diffusion, actually. At 6 months, and similar improvement was also seen at 12 months. And as I mentioned, we have 2 active clinical trials. One is called the EVER ILD trial, and this is basically looking at efficacy of lung function, efficacy on lung function 6 months after 1 course of rituximab, so 2 infusions, and mycophenolate when compared to just placebo and mycophenolate. And the other one is the Recital trial, which is basically comparing it to cyclophosphamide. The other important drug to look into is tocilizumab. We are increasingly using toci. Dr. Dinesh Khanna, he's one of the pioneers, I would say, in our times for scleroderma. Overall, he's a rheumatologist at the University of Michigan. He's kind of on most of these papers with tocilizumab that are coming out. So the earlier one, this was one of the earliest things that showed some benefit in terms of ILD. This was the Fascinate trial, which was published in Lancet back in 2016. Again, a double-blind placebo-controlled trial, 35 hospitals. So this was all scleroderma, like all comers. They were randomly assigned to weekly sub-Q toci or placebo. Their primary endpoint was actually looking at skin scores. And toci was actually not associated with reduction in skin thickening. But when they did other exploratory analyses into other important endpoints, what they saw was fewer patients in the toci group had a decline in percent FVC at 48 weeks. So this kind of set the stage for the next trial that came out, and this was published last year in Lancet, and this was what is called as the FOCUS trial. And again, FOCUS trial was sub-Q toci 162 milligrams to placebo weekly for 48 weeks. And in this study, they basically stratified the ILD based on their IL-6 levels. Primary endpoint again here was the skin thickening scores, but the secondary endpoints were, looked at the FVC percent. And what this study basically showed was the shift in distribution of change from baseline in FVC percent predicted at 48 weeks actually favored toci. So tocilizumab patients had, the change in baseline was less than patients who were on placebo. So after this study, we hypothesized that toci actually, or rather we pointed out that toci might be beneficial, especially in patients with early lung disease. Again, I'm kind of going to brush over some of these. But this study was kind of important because this looked at patients who were in the FOCUS trial. They did a subgroup analysis of patients in the FOCUS trial, and they kind of stratified these patients into their severity of ILD and fibrosis scores. So they took what is called as the quantitative ILD score, which basically is a summation. It kind of takes ground glass opacities, honeycombing, reticulation, all of these together and put them into different scores. And then you have just fibrosis scores, which just looks at fibrosis. And what we saw here was in early scleroderma ILD, we saw that tocilizumab, stabilized FVC over 48 weeks, and this was independent of how extensive the ILD was how extensive the ILD was. So that kind of becomes important in terms of being one of the important therapy options, definitely in early ILD patient, but irrespective of how severe their ILD was, TOSI is definitely an option that we need to start considering. Over the last decade, we've had 3 important trials looking at stem cell transplants, hematopoietic stem cell transplants in scleroderma patients. The ASSIST, the ASTIS, and the SCOT studies. The ASSIST was published in 2011 in Lancet, followed by the ASTIS trial. And the ASTIS is basically showed that patients, despite early in the course of stem cell transplant, patients had higher mortality, but despite this, in the transplant arm, patients had longer long-term survival benefit at years 1, 2, and 4. But this was kind of all comers for scleroderma. And I think SCOT became important because in the SCOT trial, this is New England Journal 2018, randomized phase 3 multi-center study, 75 patients, early diffuse scleroderma. And what was important was 100% of these patients in the SCOT trial actually had ILD. And they were, the patients with stem cell transplant were conditioned with, they got some cyclophosphamide, thymocyte globulin, and they were irradiated and then received a stem cell transplant. The other arm just had cyclophosphamide. And what we saw was more patients who received autologous stem cell transplant improved their FVC than those in the cyclophosphamide group. So it was 36% improved compared to 23%. And conversely, fewer patients in the autologous stem cell group worsened when compared to the cyclophosphamide group. So at 54 months post-transplant, 91% of patients in the transplant group were alive as compared to 77% patients in the monthly cyclophosphamide group. So definite, there was benefit of using stem cell transplant in a subcategory of patients who would be candidates for it. How about lung transplant? Lung transplant is definitely an option in the right kind of patients with scleroderma ILD. What are these patients? Ones who are refractory to medical therapy. Lung transplant is an important treatment option. The outcomes of post-lung transplant for patients who had scleroderma ILD are comparable to patients with other fibrotic lung diseases such as IPF. Important things to consider: cardiac disease, right? So patients with scleroderma do have an increased risk of cardiac disease, as we discussed earlier, diastolic dysfunction, things such as pH. GI complications become important because these patients are already at risk for GI dysmotility. So this should be taken into consideration when considering lung transplant options. So this study kind of looked at, was published in one of the rheumatology journals, kind of looking at different centers, and they compared, survivals and CLAD rates, so the chronic lung allograft dysfunction rates, amongst patients who had lung transplant for scleroderma versus other lung diseases. So it can be IPF, PH, things like that. And what they saw was that the survival and CLAD rates are comparable. So short-term and long-term mortality are comparable to other ILD groups. So it is definitely a treatment option. It's not worse than other ILD. So lung transplantation should be considered in patients who have severe ILD refractory to first-line therapy. But also the important thing to consider, as I mentioned before, was having non-severe extrapulmonary disease becomes an important thing to remember in these patients. So how about the future? Pirfenidone is being studied. This was the Lotus trial that came out in 2016. Lotus basically was a phase 2 trial looking at pirfenidone in patients with scleroderma ILD. And what it showed was pirfenidone administered either as monotherapy or in combination with mycophenolate had an acceptable tolerability profile. Most common adverse effects were similar to what we're seeing in the IPF trials before, and those were nausea, headache, fatigue, things like that. We have an ongoing SLS3, which is a scleroderma lung study 3 trial, which is looking at pirfenidone plus mycophenolate or mycophenolate alone in scleroderma patients. These are some of the important inclusion and exclusion criteria that they're looking at. They're targeting patients who are taking in these medications for less than 6 months, and we are comparing mycophenolate with placebo versus mycophenolate with pirfenidone for 18 months. The primary outcome is going to be FVC percentage 18 months. So stay tuned for SLS3 to come out. Another important treatment option is something called abituzumab. This is an interesting pathophysiology because TGF-beta is actually activated by a class of integrins, which is called the alpha-5 integrins. Abituzumab is a monoclonal antibody that inhibits the activity of this alpha-5 integrin. This was a phase 2 double-blind parallel group trial. Basically, it was a 2-2-2-1. So patients were randomized to either received abituzumab 1500 versus abituzumab 500 versus placebo, and the trial was prematurely terminated because of slow enrollment. But what we saw was this was pretty well tolerated. So I'm not aware of any active phase 3 trials for abituzumab right now, but in the future this could be a consideration. Other things to remember, as with any of our other chronic lung disease patients, we always need to talk about things such as smoking cessation, vaccines, pulmonary rehab, need for supplemental oxygen therapy, lung cancer screening in the right kind of patients. Other pulmonary comorbidities, as with any of our other chronic lung disease patients, these patients are at risk for chronic aspiration, neuromuscular disease, at risk for thromboembolic disease, pulmonary hypertension, and also sleep disordered breathing, and treatment of other important comorbidities such as depression. They're on, some of these can be on low dose steroids for long duration, so they may be at risk for osteoporosis, cardiovascular disease, cachexia, things like these. So general treatment considerations, as with our other chronic lung disease patients, need to be considered. Last couple slides on prognosis and mortality. As I mentioned earlier, things such as FVC and high-resolution CAT scan early in the course of disease have prognostic utility. This study kind of looked at PFT trends, and what they concluded basically was, in terms of prognostic significance, what PFT changes had the highest prognostic significance, and that is a decline in FVC of more than 10%, or a decline between 5 and 9% with a concomitant decline in DLCO of more than 15%. This, had either one of these had a very strong prognostic significance for worsening of ILD in these patients. Some of the other predictors of mortality, obviously higher age males have a higher risk of mortality. PFT values, that some of this we talked about, higher extent of disease on imaging, some bronchoscopic variables. So if you had a higher than usual eosinophils, neutrophils, this would put you at risk. And some of the other lab studies that we talked about, so CRP, KL6, things like that. And scleroderma specific variables, so having PAH concomitant, having a pericardial effusion, put you at risk for increased mortality in patients with scleroderma ILD. Number of things to consider here. So overall, when we look at treatment approach, I think this was an excellent slide, dividing ILD into the subclinical kind and the clinical type. So when you have subclinical ILD, they are at risk for progression, although they're at low risk for progression, so you continue to monitor them. But in patients who have higher risk of progression, potentially even with subclinical ILD, there could be candidates for, what is called as early ILD therapy with either TOSI or mycophenolate. And in patients with more of the clinical ILD, more obvious involvement, you would kind of divide them into having a predominant lung involvement with absent skin involvement, or more of, the multi-organ involvement kind. With the predominant lung involvement, starting them off with nintedanib or immunomodulator therapy, or even a combination of these, become important. But more with, if you have more of the multi-organ involvement, then starting off with immunosuppressive therapy is the way to go. And again, after starting off these therapies, we need to understand the options for escalation. So hematopoietic stem cell transplant in the right kind of patients, adding Ritux, changing cyclophosphamide to mycophenolate, and obviously lung transplant referral become important. So overall take-home points: ILD is important in scleroderma. 50% of your patients with diffuse scleroderma have ILD. 25% of your limited scleroderma patients have ILD. It is the main cause of disease-associated mortality in scleroderma patients. Remember that FVC decline is important, and early FVC, in the first 3 to 5 years, if you have an FVC that is low, fibrosis that's more than 20%, these are the patients who have high risk for progression. ILD is so common that these patients with any scleroderma patient should be screened for ILD and PH at the time of diagnosis. If they don't have it, they should be screened at regular intervals. And if you have an FVC decline of at least 10% or a DLCO decline of 15%, this should raise concern for progression of disease. And just to kind of give you, a quick recap, scleroderma is a multi-system disease. You have different organ involvement, and being cognizant of this disease and its associated ILD is definitely important. Thank you, and I'll take any questions.
I think the FPC, they find it lower FPC at initial diagnosis, it says they have worse progression. Is that just going to find me later in the disease course, or is it like if I showed up late, been having symptoms for a while, but I only diagnosed for a year, my FPC is lower than so you would go to screen, you're at 100% or you're at 90%. Is it just because my disease that it was caught later in the clinical course?
Yeah, that. Again, it's both, I would say. So either you presented so late in the disease course that your FVC is already it is at a point wherein you have progressed to a point wherein you already have advanced disease, or you could be a phenotype of scleroderma ILD who has more of a rapidly progressive kind. So I think it'll have to be put into context, but I think overall patients who do present with a lower FVC have a high risk for progression when compared to patients who did not have a low FVC on presentation. And the first 3 years of disease diagnosis is an important marker. And more severe, they have more worsening progression. Significant. Absolutely, absolutely. So, yeah. So the minimal importance. So one of the studies that looked at the follow-up study for mycophenolate, right? So what was considered minimal, I'll have to go back and check, was a 3% change is considered a minimal significant difference. So, 4% is definitely, something which for obstructive lung disease is important, but with ILD, will have to be a little more on the sensitive side, having a lower FVC goal. Any other questions I can take? Thank you.